So today I'll be discussing more about what is the SAM device itself, Sustained Acoustic Medicine. I'm really looking forward to answering questions at the end of this. I think this is a very novel device. I've been with this organization for the past 5 years, big user of it, an advocate of it as well. And the clinical research that has come over the last few years, especially over the last 3 years, has been very monumental in the shift of how the SAM could be used, both in the workplace environments for work compensation, as well as helping patients return to not only work, but their quality of life and helping athletes as well. Our main goal for today is that what we're going to be talking about is not only the SAM, but the research behind it and also different types of injuries it could be applied for. So let's dive right in. The only disclosures I have is in addition to working with Yale, I also do clinical education for the SAM company as well for Zetros. All right. So before we talk about what the SAM does, we really have to do a deep dive into what happens when someone gets hurt. That's looking at soft tissue injuries. Now, three things happen with any type of injury. And this is, by the way, the body's natural physiological response. The first is when there is an injury, someone has inflammation. With inflammation, this is what's going to happen in that acute stage. Perhaps you put too much weight on your leg when you were squatting. You may have pulled some muscles in your rotator cuff as well. You may have some type of hip osteoarthritis. During that time, the body is going to have immediately swelling, a lot of tissue to the area of injury, or blood flow. That's going to cause that pain response. In addition to the warmth, the swelling that's there, this is also the body's way of helping protect yourself as well, too. This way, you're not putting and exposing that injury out to get further hurt as well. Your clinical priority, typically in this case, is what you're going to do is to try to reduce some type of inflammation because of the pain being so severe, and in the hopes that this is able to get you to the repair process. Now, one of the main issues with this is that when you're having some type of these injuries, you have to understand that you don't want to be issuing too much NSAIDs early on, as this could also delay the repair process for you. So what happens during the repair process? This is now when inflammation is going down. Now you're able to lay down collagen for soft tissue injuries such as muscles, ligaments, tendons. And in addition, now those fibroblasts are getting laid out. You're rebuilding things back in the hope that it can mature into stronger tissue, and it matures in a way that it can sustain previous loads that it had before. But the problem is when people are in the repair process, there's different things that may impede them from repairing sooner. First and foremost, we have to look at their age. Patients that are in their 20s are going to repair much faster than someone in their 70s, 80s, and 90s. In addition, what is their previous status? Were they a professional athlete, or is this someone who's mostly bed-bound, wheelchair-bound, or been walking around with a rolling walker? What is also going to be their level of improvability based off of what are their comorbidities? Are they a young and healthy person, or are they someone who's also got COPD, heart failure, different types of also issues that may impede their quality of life recovery? But when we talk about them going through the repair process, there's lastly remodeling. And remodeling is now where the tissue itself is being able to get strong enough to its previous way before, able to sustain that load, that explosiveness. Perhaps they were a basketball player jumping up, be able to land back on their feet without pain. And now that immature tissue that was laid down from the collagen is now stronger. So it's matured in a way. And in this case, now those patients are able to return to play or return to work. What we want to find is, as I go through this presentation, what's really important and why I put the slide first is we will be referring nonstop to this process, because what the SAM is able to do is it shortens the time frame patients are in this, in which case there's a shortened time frame of inflammation, shorter time frame of repair, and shorter time frame of remodeling. Which means that even though it's shorter, the body is able to go through the phase faster in completion to allow you to go to the next phase. I don't want you to think that this is just shortening the process without it sufficiently going through. Rather, it's enhancing it so it's faster to allow you to finish that phase, go to repair, go to remodeling, and in turn get back to play, get back to work, get back to doing what you enjoy to do. But in order to really take that step back, we have to look at what ultrasound does and how it could do this on a cellular level. This really comes down to two main aspects of it. There's thermal benefits and non-thermal benefits. Thermal benefits are in regards to heat. When you apply someone with heat, immediately they're going to get some type of pain relief. There's vasodilation as well, more blood flow to an area of injury. But that itself isn't what is novel about ultrasound or even about the SAM. You could have, for all intents and purposes, you could have some patient even take a towel, wrap it up with rice, put it in a microwave, put it over their neck. They feel pain relief because there's heat, but it's not doing what's non-thermal. Non-thermal benefits of SAM come down to four main things. And this is what we refer to as the biomechanical stimulus. This is the foundation of how ultrasound is able to help patients on a cellular and physiological level. What happens in these cases is that there's, with ultrasound, compressive forces, in which case the ultrasound itself, as it enters into the body, is able to press onto the cellular matrix and also expand tissues. That also stimulates growth and repair. In turn, there's also shearing forces of friction, in which case the cells themselves shift around. They also turn on a rebuilding process. There's also microbubbling and cavitation from those forces, which release heat. And lastly, there's more bulk flow. So as the ultrasound's coming in, you want to think of almost like a river, in which that flow of ultrasound, that flow, that water flow is going into the area of injury, and that's stimulating more transport phenomena, whether it's removing lactic acid tissue, or in turn, it's working on any type of issues with regards to patients of how it's able to deliver the ultrasound. As far as contraindications, Cindy will go into this a little bit more towards the end. Please save your question, but we will go into contraindications, also bleeding risk as well too. I have a slide specifically about that. So if I don't answer everything, please ask me at the end on the Q&A. So with these four different aspects, now you could be able to get thermal benefits of heat, but also the compressive force, the shear force, the microbubbling cavitation releasing heat, and the bulk flow to all work on a physiological level to enhance recovery process. And in turn, what happens is we could divide up of how it's working on the body in three different ways. As you can see from this slide, when the patients themselves are having the use of the ultrasound placed right on the skin, that transducer is able to provide for those patients some type of aspect of them getting the ultrasound to have more vascularity to be applied. Again, it's pushing that ultrasound through to the soft tissue. In addition, we're also having those patients get increased capillary permeability. Now those capillaries are opening up. There's more bulk flow to there. There's more exchange of the nutrients than the oxygen, removal of the lactic acid, and now that injury could get repaired quicker too. In addition, because we talked about the heat component and the bulk flow, now the ultrasound is also working on the actual blood vessels to dilate them. So now I have more blood flow there. Exchange, it's going on at the cellular membranes as well too, in addition to the extracellular fiber matrix, and those begin the repair process. So you have three aspects from a macro level and a micro level as well, and also on the cellular structure around it too. I'm going to play this video here for us so we can summarize what I've discussed with some animation videos. I'll turn this on for us.
Tissue remodeling is a complex physiological response that occurs after an injury. Natural limitations to this process often lead to mechanically inferior tissue, adhesions, and chronic pain conditions, especially in tendons, which have limited blood and nutrient supply. Sustained acoustic medicine, or SAM, is a new wearable technology that utilizes mechanical ultrasound waves to promote the healing cascade. Different from traditional ultrasound, SAM applies a mild mechanical stimulation to the tissue over multiple hours, providing enhanced recovery benefits. SAM's continuous ultrasound waves produce a convective flow called acoustic streaming up to 5 centimeters into tissue. Combined with an increase in heat and circulation, the sustained mechanical pressure increases the bulk flow, pumping nutrients and growth factors throughout damaged areas, enhancing natural healing. When SAM is applied, the mechanical forces activate cell membrane receptors, enhancing cellular proliferation. One important mechanism is the upregulation of transforming growth factor beta, which increases type 1 and type 3 collagen deposition and promotes native tissue regeneration. The result is greater tensile strength and improved biomechanical properties of the tendon. Sustained acoustic medicine, SAM. Great.
Glad we got to see that as well. So what we can get away from this is looking at patients with how it's this device itself is the first and only FDA cleared non-surgical device. It's wearable. It does long duration therapy. It's going to be looking at reducing inflammation and accelerating the soft tissue repair process. So it could be used for 1 to 4 hours as well. Deborah, we're going to answer your question from some of the slides. Yes, it can be used for older injuries, but you're going to see some different variability versus acute. So we're actually going to go into that in some of the clinical research in the next few minutes as well. Again, for everyone, if there's going to be a big Q&A at the end, but I want to make sure we can address all these questions as we go through the slides. The nice thing is we've been backed up with over 30 different research trials as well. And again, it can be used for acute injuries as well as for chronic pain, which we're going to go through as well. What I also want to take a step back to is looking at how this device is different from what's going on currently with ultrasound. When we look at ultrasound as well too, ultrasound devices now are used with patients typically going into the office and kind of adjusting their settings. So there's 3 things that need to be adjusted when it comes to it. There's the frequency, there's going to be the use of the intensity, and also the duration and energy that's applied. But typically, with these patients, they come to the office, you have an athletic trainer, sometimes a doctor, or someone that's coming into the office, be able to adjust the device, but they got to drive in, set up an appointment, and then they get their treatment for maybe 5 or 10 minutes, in addition to other physical therapy, and then they go home. But with the SAM, we can have patients be treated at home from the comfort of their home or even at work, in which they could get some of their benefits. In turn, they also don't need to change the intensity or change or maneuver the frequency. Typically, when it comes to the SAM, typically when it comes to research, there's going to be some type of use of the SAM using 3 megahertz, which typically from clinical research of ultrasound is going as much as 2 centimeters. However, because there's the transducers used for a longer period of time, patients can have as much as 2 inches of depth of perception, which is about 5 centimeters. In addition, there's a longer duration on there. Now, most people get concerned with, wait, you can't have ultrasound on for 1 to 4 hours. It's only a few minutes. But because the intensity is lower, this allows patients to be safely using the SAM device without any type of heating trauma to their injuries, okay? So there's actually a safety mechanism within the SAM in which it is able to detect what the temperature is, prevent it from going too high or even too low, in which case it keeps it at a nice plateau. So this way patients are getting a therapeutic benefit sustained without it getting too high to cause any type of heating tissue injury. In addition, you can see that the joules here is significantly higher at 18,720 joules, as opposed to what's typically used in an ultrasound clinic of 2 to maybe 5,000 joules. Now, this is huge because now we're able to give a larger dose to patients to cover a full spectrum of injuries. In addition, you can give it over a longer period of time, which means 4 hours of the following: 4 hours of heat, 4 hours of that convection blood flow, 4 hours of that compressive forces, 4 hours of the shear forces, 4 hours of the microbubbling and cavitation, 4 hours of all that bulk flow to the area of injury. Those in turn improve all those benefits that we talked about from the earlier slides, allowing you to have greater vasodilation, more capillary exchange, more nutrient flow, the activation of the cellular structures and extracellular matrix, and the enhancement of the collagen matrix rebuilding process. And in turn, that allows you to go through inflammation, repair, remodeling much faster. This device is also different from what you may see from some bone healing devices, because those use pulse ultrasound. This device uses continuous ultrasound, which again has been commonly used for soft tissue healing as well. So we can see that there's those differences in the use of the SAM. I do want to take this moment, though, to compare it to what's seen as a TENS device. Sometimes when people see this device, they think it may be similar to a TENS. The difference is with the TENS device is that this device, the SAM, treats the underlying injury. A TENS device It's used as a pain modulator, in which case you turn it on, patients get some pain relief, turn it off, but you're not treating the underlying cause of the injury, not treating what's happening to the muscles, the ligaments, tendons, or even with disadvantaged back pain. But with the SAM, because I'm treating the underlying cause, as we discussed repeatedly over the last few slides, that patient's not only going to get pain relief, but also in turn be able to be strong or to get back to doing what they're doing as well too. In addition, when we look at the energy that's applied with the SAM, it's significantly larger than traditional ultrasound, which allows patients, without adjusting the device on their own, be able to treat a large spectrum of different injuries, including a mild calcified tendonitis to something that's more severe, or even deep hip osteoarthritis, which may require 4,500 joules, or for a supraspinatus tendonitis, about 4,300 joules. All these different variations can be treated, but again, all they do is they put on the device, they turn it on, let it do its work without need to make those adjustments. So it's very user-friendly for that reason. And in fact, when patients put it on, as you can see from here, there's going to be a blue button that they press. That blue button allows the patients to go ahead and use that. Use my little cursor. And then on the right side is another blue button that adjusts for the 1 hour, 2 hours, 3 hours, and 4 hours. They put the ultrasound patches on, and they just apply the device on as well too. Okay. I'm going to just take this moment. I understand there's a lot of different questions. They will all be addressed as well. The next one's from Teresa. Needs an MD to be ordered. As for the recommendations of this use, we're going to go through that in more slides, Tara. And then for Lisa, I'll reach Matt afterwards. Going to be working with the team to send out a handout as well. So that will be followed up too. But we're going to go into more of these questions and contraindications as we go through this slide. But I love the questions already. We also have a second device called SAM X1. This is also being used too for more regenerative medicine side of things, because again, this battery life is a little short. It's at 1 hour. Okay. Some of our athletes use it more as something that use post-workout or after a game, in which case they don't necessarily have a severe injury, but rather want to be able to be strong enough to recover maybe some soreness to get back to play. This is something on a personal aspect I myself use more often. Fortunately, I'm not injured, but I use it pretty regularly throughout the weeks. This is a portable device, as you can see here. There's no wires as opposed to the other slides. This one allows patients to just plug it in, turn on the device, and they're good to go. We use these devices for many professional teams. We're also in several D1 athlete teams, D1 Division I sports teams as well. It's very popular with our aging population, as well as we're big advocates with our U.S. active and veteran military, as well as Medicare patients. And one of the big things that I'm excited to talk about is our clinical research. So I'm not going to go into all the clinical research here. That would take several hours, but I am going to highlight some of the big studies for us here. And hopefully this will answer several of the questions that have come on to this as well too. First one I want to go through is a meta-analysis. For those of you who may not be familiar, a meta-analysis is a systematic review, uses data from multiple different research trials to try to come to a conclusion of what are these different outcomes say, and we could come together with the conclusion of what would be the question that was to be answered. And in this case, we're looking at the use of the SAM. We're trying to figure out, is this a good therapeutic option? Does it help patients with pain control? Does it help patients with their function, their mobility, their strength? Does it reduce their soreness for different types of injuries such as the knee or the shoulder or neck? So we looked at all these different trials from 2010 to 2021. And what we were able to find was many of these questions could be answered. They came down to 13 different trials from many that were searched. And again, these are looking at what's happening with the SAM using those mechanisms. Seeing again in that first slide over here on the left side, you're seeing how does it help with the soft tissue injury? How's it helping on the heating aspect with the capillaries? How's it helping the blood flow? What's happening at the physiological level? So one of the big questions that was answered was looking at shoulder and neck injuries from a pain and health quality improvement score. And as you can see from these studies in the top side from A, patients were having a significant improvement, as you can see from the green that's here on the right side versus placebo. In addition, when it came to quality improvement as well, how they feel about their day-to-day life, there's a significant p-value reduction of 0.00001 for those patients of how they felt about their everyday quality of life. And that's very exciting because when you look at these patients, many of them have been dealing, unfortunately, with some chronic pain, with these acute injuries. They're not able to do the things that they may enjoy to do. For some people, it may be throwing a football. For others, it may be just holding their grandchild in their arms or being able to go out and do gardening or even go to a grocery store on their own. We also looked at patients looking at knee joint diathermy, which is heat. Again, you saw from previous slides as well for this too, that these patients were also getting some differences in heat. We did some different trials a few years ago looking at the SAM versus 3 different aspects of heating that were compared by scientists, including whirlpools, paraffin baths, and hot packs. They were looking at what the temperature changes were at 1 centimeters. With those 3 devices measured at the human triceps, they were finding that those 3 devices heated up the temperature by as much as only 2 degrees Celsius. But once it got to a greater depth, as much as 3 centimeters, there was no temperature change at all. As opposed to the SAM, as you're seeing in this slide, when it came to 1 centimeter of depth, the temperature could raise up as much as 6 degrees Celsius. But when it came to 3 centimeters, it could heat up as much as 4 degrees Celsius. So what you're seeing is that the ultrasound is therefore the desired modality to be able to do some of that soft tissue heating deep inside, especially with things like the hip or deep into the shoulder as well. Again, some of those larger muscles, the quadriceps, hamstrings, those had deeper penetration, which is what you're getting with the SAM. So from these different trials, there were 13 of them. They overall showed some improvement in the pain function, healthcare qualities. There's even a trial from Draper that was published as well too, looking at patients with knee osteoarthritis. This was done in 2018. This was showing patients having with moderate to severe osteoarthritis as much as a 505-point improvement in their function score with the WOMAC score as well too, which is really exciting again as well, because again, when it came to osteoarthritis, even though it doesn't fit necessarily with the classical soft tissue injuries of muscle, tendons, ligaments, even with bone on bone, patients are getting some of that pain relief too, as it's slowing down some of the osteoarthritis that's degenerative from degenerative disease. When we break up the trials a little bit more, we can also see how it's affecting things on different things, such as the tendons. So in one study by Dr. Bess, he looked at different types of injuries, such as elbows and Achilles tendinopathies. He was finding that there was 100% patients having improvement. This one was a smaller trial, about 25 patients, but showed that even with the use of the SAM 4 hours a day, 5 times a week, for as much as 6 weeks, they were having their elbow tendinopathy scores of their pain reduction reduced as much as 4 points, 3.94, as well as improvement in their grip strength. And these greatest improvements were in those first initial 2 weeks. As you can see from this slide here, they were up here, I wrote it at 5. They came down to the mid 3s. Again, compared to the placebo trial group of this slide, much more of a larger improvement as well too. So the earlier the SAM is used, the quicker it helps with reduction of pain and return of function for an acute injury. They also showed even with those with Achilles tendinopathy, there was a significant reduction of pain and improvement as well too. When it comes to soft tissue injuries, we could also look at how it could be used as an add-on therapy. In this trial by Draper, he was able to look at various different types of patients. There are several, about 18 in a case series. In this case series, he had these patients using the SAM after they spent a few days or weeks not having improvement with their standard of care. And again, standard of care is going to be physical therapy. But when they had the SAM added on, those patients were able to decrease their pain by as much as 3.3 points. They were all very satisfied with it. There was an 87% improvement of their function score and 50% return to work after 2 to 4 weeks of the SAM. Again, this was a various different types of injuries. This was looking at things with the knees, shoulders, hips, neck, back, various types, just a case trial. But again, showing the benefits of the earlier it's added on, you could have patients improve. And also, even when things are stagnant with PT, if it could be even a chronic injury, patients are getting improvement scores as well too. This one was also exciting. While it's not necessarily published yet, it is going to be something that is currently being drafted to be put under review soon. It was looking at workplace injuries and how patients were affected from a work compensation standpoint. They took 77 patients in Colorado with various injuries, as you see here, elbows, shoulders, back, ankle, knees, wrists. And what they wanted to do was look at what happens with when there's the maximal medical improvement, and then in which case they failed. This is very similar to the Draper trial looking at athletes, which is they did the physical therapy, they didn't get better, SAM was added on. This data that I'm showing you, this data set's looking at workplace, not athletes, of how they did, in this case for elbow injuries, 19 physical therapy sessions, were not getting improvement, then got the SAM, applied for 8 weeks, and their scores for their function of their elbows went from 3 to 8, so a 5-point improvement. In addition, for their shoulders, again, these are work compensation patients, not athletes. They again also got stagnant after 24 sessions of physical therapy. They had the SAM added on after 8 weeks. Their shoulder scores went from 4 to 10. Significant improvement, about 250%, in which case now they're able to have significant improvement and return to work. We also looked at patients even with lower back injuries, which are horrible injuries that really are debilitating for patients long term and really affect their ability to even get back to work or even have a good quality of life. These patients went through 34 physical therapy sessions, and then again, not having significant improvement, had the SAM added on, and then after it's added on, their scores went down. In this case, lower scores indicate higher function. Now, when they had it on, they're able to return to work a lot sooner as well too. So key takeaway from this is knowing that regardless of what you're getting with physical therapy, when you have an added on SAM, even if it's later in the injury as opposed to acute, patients are having improvements of their scores. But again, the earlier things are used, of course, you're going to have better outcomes. From here, we're able to see that also too, if we extrapolate this data, we can see it can even save patients and for as much as $27,000. So if you have patients go with the SAM, they're out of work, they may need to go for further imaging and PRP, maybe surgery, there's post-op, they're out of work for 26 weeks. You now save patients money by, and the healthcare service as well as money by having them return to work. So these are cost-saving benefits, which are pretty significant as well too. We're really excited to hopefully be publishing this study very shortly too. In addition, I wanted to take a step back, talk about pain. So there are some questions as well in regards to what are we doing about patients who have injuries later on? Does this have benefits for them? Well, as we've seen, there are benefits for patients, regardless of whether it's acute or chronic. But when it comes to chronic pain, especially in this world that we now have as an opioid crisis, we have to look at how patients can get pain relief in a safe manner that's not addictive, especially when it comes to opioids. In addition, we also want to look at, from someone's earlier question, how we can give pain relief medications without also having them get some type of different risk, so such as bleeding or there's contraindications. When it came to sonophoresis, that is the use of ultrasound to help with drug delivery. This has been used also previously for even cancer patients as well, drug delivery, but this is localized drug delivery. This has multiple benefits. One, if a patient's on anticoagulation, they have NSAIDs, so that, in addition to Eliquis or Xarelto or warfarin, they're at a higher bleeding risk. But if you take it by mouth, you could also have risk of GI bleeds. You could also have nosebleeds. You could also have irritation to the gut, causing gastritis as well, risk of bleeding. There could also be issues with chronic kidney disease that you could develop. However, if you use diclofenac in a localized manner to the area of injury, this can also reduce those side effects, allow you to still take your anticoagulation medicine, or also continue your treatment for your chronic kidney disease, but you're getting a focused dose to the area of injury without affecting some of those other organs. And what happens is with Masterson, they were able to show that with sonophoresis, these patches in particular were able to deliver the drug 3.8 times faster. So patients get significant pain relief. In addition, which is very exciting, patients in a trial by Mediza were able to have significant pain relief, in which case there was a group called rapid responders. Rapid responders reported pain relief on the first treatment, not the first week, the first treatment. This is huge because now you have a way to give pain relief to patients, increase their compliance of the use of the SAM. You're doing it in a way that's non-addictive with reduction of side effects, and they feel better. And that's huge because now you can improve the quality of life. If someone feels better, they're more likely to do rehab, they're more likely to keep using the SAM, more likely to be compliant with their treatment. That's huge. And from this, we were able to see that when patients had this applied on, especially with the damage to any type of cartilage or overuse injury, right here at that week 1, week 2, that entire group, that's the rapid responders that felt pain relief from the first treatment, comes down significantly compared to anyone else in the placebo or the SAM only group, and then the SAM and diclofenac group. So huge benefit by combining that treatment to give them that pain relief. And it's about 50 to 70% pain reduction the first week alone. Tremendous, tremendous. And the quality improvement goes up. And again, the knee function goes up because now you have pain relief. In addition, for that group, there's a 94% retention rate. Their pain scores over 7 days went down about 50%, went about 2.96 points, about 70% again compared to where they started at. Their functional scores from WOMAC also improved by 351 points, as well as 510 for the rapid responders. So tremendously promising. So that study was built on a little bit more in 2023. There's another study by Jarrett, which shows patients who have failed, rest ice compression, with RICE therapy and elevation, and they did their PT. Again, we're seeing a group who's similar to what we saw with Draper. They had athletes who did PT, didn't get better, had an add-on. This is also similar to the Colorado study, which we're working on publishing, showing workplace injuries that occurred, patients not doing well, then getting an add-on SAM and feeling better. Now this one's looking at patients who again failed PT, not getting better, but having the SAM on with 2.5% of the diclofenac patches. This one now had pain reduction by as much as 4.44 points, health improvement scores up by 4.85 points, overall 97.8 showed improvement. Tremendously promising, tremendously promising. So when you compared all these different groups from their injuries, you could see that their quality improvement scores significantly improved from pre versus post, and that all these pain scores are going down across the spectrum. Nobody's gone up, they're all going down. And again, that's because we're having that combination of the SAM, which is thermal and non-thermal benefits, and also the localized pain release of the diclofenac patch as well, helping those patients too. Now, when we look from a professional side of things, what happens to athletic trainers when they use a SAM, this is also promising because these are the people that generally in a sports context, in addition to doctors, are seeing the patients on a weekly basis, seeing how they're doing. So they surveyed various of these patients from the National Athletic Trainers Association, found that from that group, they looked at mostly 83.9% musculoskeletal injuries. From that group, that's the survey showed of the athletic trainers, typically in under 2 weeks, there's 68.9% reduction of there's a 68.9% clinical improvement and a 50% reduction in pain, about 63% of the time. Tremendous. Again, it's that early onset use of the SAM, which is going to be the key game player. And the patients themselves were very receptive to this as well from them. When we look at also discogenic injuries as well too, this is going to be patients with severe back pain, could be disc herniation as well. These are patients that again were used with the SAM compared to a control group. And just as to build on Susan's question, how do results compare from the general population to work comp? These studies are looking at with this focalized population, whether it's a work comp study, is working at work comp, is working at athletics, athletes going to be focused on athletes. And when it comes to older patients as well, be with an older patient. So it's difficult to spread this out to a whole general population because again, we're looking at different types of injuries for those populations. In this case, for this group, these were patients with discogenic back pain, patients older than 50s. In which case we split them up and we're able to show that when they had disc herniation, which was captured in MRI, We split them up. We applied the SAM on, as you can see here, on both sides of the spinal column on the lower back. Those patients had significant reduction of their pain by 2.58 points overall. Now, where you see the greatest reduction, as you see from this slide, is typically at the 2-week point, where it drops from 0 all the way down, and it's able to sustain down there, and then a little bit going down for some of these patients with chronic pain. Also exciting is that there's a 22.5% reduction in the use of opioids. Again, I want to stress this. We're trying to find alternatives for patients that have pain control without having them use opioids in a way that is detrimental with addiction. And in turn, we're trying to find a way where they're going to be compliant about it. In this study, which was exciting compared to the placebo group, these patients had significant reduction in pain, increased quality of life, and reported wanting to continue to use the SAM post-study. 100% of them in the SAM group felt this way. And again, that's going up how you could treat chronic pain. So what we're seeing is different ways patients are treating acute injuries, and we can see how the SAM could also help with even the chronic pain standpoint. And this study was done also too, looking at those as well that have been having debilitating discogenic pain injuries. We can look even at younger athletes as well, and looking at sports medicine doctors, what they do. Commonly, for even some type of knee injuries or shoulder injuries, you may see patients getting PRP. Some doctors love using this and they'll stick to it, which is great. It's been shown to work. But because of what we've seen with sonophoresis, the SAM can also help with that delivery and have the PRP be able to enhance its delivery as well, enhance the recovery process. And when in this case, compared to a SAM and PRP group versus just a PRP group, we also have patients with the SAM and PRP return to play 21 days faster than just PRP alone. This group showed a reduction in pain and also improvement of their healthcare quality scores. And most exciting of all, in 6 weeks, there was no re-injury followed up, which is huge. Now you found a way to get them better and keep patients safe. Hugely beneficial. What the direction now we're looking at, so we're looking at now some studies looking at bone healing, more studies of knee osteoarthritis, as well as soft tissue injuries with return to play, and also more studies on looking at sonophoresis. This is going to be sponsored by the NIH, and also the Department of Defense, as we work also with some trials with veterans and active military personnel. As for the dosing parameters, I think this was a question really early on. We're going to be looking at these patients as well of how they can be dosed appropriately. Patients get the dosing in these studies, typically 4 to 6 weeks, as we've talked about. However, based off the injury, you could do it a little shorter. For the medical research purpose, again, we're showing them we're showing these benefits over a long period of time. But typically when it comes to muscles, because they're highly vascularized, they're going to be able to recover faster, maybe 1 or 2 weeks. This could be an example of you go to the gym, you may feel a bit sore, you're not injured, you're just feeling pretty tight, maybe in your lower back, your quads, your biceps, your chest. You can use the SAM, you're going to feel better. Some tissue that's less vascularized, such as connective tissue, tendons, ligaments, may need a longer treatment. Okay, this could be maybe you had a bad injury on a quad tendonitis, an elbow tendinopathy. You're going to be applying it for a longer period. Bone joints on bone, that could be something at 6 to 8 weeks, sometimes longer, especially if it's severe osteoarthritis with chronic pain. So these are different parameters that you're getting seen. You can also see how the device is placed in these slides. You typically place the devices about 2, if they're next to each other, probably about 2 maybe inches apart. If it's going to be in a capsule area, such as the shoulder, you usually have it penetrate from the front and back if possible, but you want to get a nice larger area the size of a grapefruit if possible. This way you're allowed to get that deep penetration, treat that entire tissue area as well. You can also see it applied in different areas such as the hamstring, the biceps, put on your abs as well, or your obliques, ankles, all these various different areas that we've mentioned before. I do want to end here and open up to questions of going back to the healing process. We did talk about inflammation, repair, remodeling. Inflammation, you're going to get hurt. There's going to be swelling. There's going to be pain. The SAM now is able to come in. It's able to improve that blood flow to the area of injury, starts working on helping patients get through that stage quicker, as now you could do more upregulation of TGF beta in the repair process. Now you're laying down more fresh collagen. It's going to be over time, start maturing in the remodeling phase. Now that tissue is going to be stronger to withstand those injuries, so you can get back to that explosiveness that you had before and be able to do some of the quality of life activities you may have enjoyed. Really appreciate everyone's time. I know it's right now around 12:47. I do want to open this up for questions, and I also have Matt on as well. So please fire away any questions into the chat. Okay. Matt is going to hand out some handouts. As for contraindications, going back to an earlier question, I think was from Cindy. So yeah, you can use it if someone is on antithrombotics, anticoagulation, that's fine to use. As far as specific contraindications, we do not recommend it's being used on any site of solid malignancies. For example, if you have breast cancer and you have really sore part of your pectoral muscle, do not place it on there. If you have a kidney cancer and it's affecting your back, we wouldn't recommend to apply the SAM directly over that area. If you have an elbow injury and you have stage 1 kidney cancer, yeah, you can use it on your elbow. I mean, it's a long way from here. We also don't recommend it for anyone with any blood cancers. If you have any type of deep brain stimulation, it shouldn't be used if the patient has a pacemaker as well, or any type of ischemic tissue, severe peripheral vascular disease. We wouldn't want them to be used as well, particularly because it's going to, if you have peripheral vascular disease, it's like near your toe and you're using it to near your ankle, because there's less blood flow there, you're going to be able to have less blood supply. It's unable to increase the metabolic demand. You could have some necrosis, so we would avoid that as well too. All right, so in summary, nothing directly on any devices, nothing to be used for any area or limbs that specifically have peripheral vascular disease, and do not be applying on any solid organ cancers. Well, thank you everyone for your time, and